we come to the end of your presentation, sir. Thank you so much for joining us, sir. Our next speaker will be Professor Said Abdelhamid from South Valley University. Professor Said will speak about extracapsular neck fractures. Professor Said, please, sir.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I'd like to thank Professor Mohammed Al-Ashhab for his marvelous effort in spreading knowledge. And I am honored to be side by side by my great professors.
Professor Said, you are muted, sir. You are muted, sir.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum assalam wa barakatuh, Ustad.
First of all, I'd like to thank the Egyptian Orthopedic Association, in particular Professor Mohammed Al-Ashhab. He is doing really marvelous effort in spreading the knowledge في ميزان حسنات حضرتك إن شاء الله. And I am honored to be side by side to my great professors and mentors in this session. And I'm going to talk about the extracapsular hip fractures. Actually, we orthopedic surgeons have a different understanding of hips. And this is Shakira say that hips don't lie. In fact, sometimes they do. As for hip fractures, they are classified as my professor Mohammed Shafi said into intracapsular fractures, previously talking about by Professor Eid, and extracapsular fractures that includes trochanteric and subtrochanteric fractures. In fact, extracapsular fractures, approximately 40% of all hip fractures, 90% of them are trochanteric fractures. Intracapsular fractures, as mentioned by Dr. Eid, they are famous for two main famous complications, which are the avascular necrosis of the head of the femur and the non-union. Fortunately, those complications are rare in extracapsular fractures because of the rich vascularity in this area. They tend to unite, however, they tend to unite in various positions. Why are those fractures important? Because of the high incidence of 1-year mortality associated with those fractures. In fact, those fractures sometimes are the beginning of the end of the patient's life, to the extent that we say we come to life under the brim of the pelvis and will leave it through the proximal femur. Mortality, 1-year mortality rate is variable in different series, reaching up to 58% in some series, and those are higher than the femoral neck fractures also. Clinical diagnosis is straightforward, just fragility fractures that is defined as falling from a standing height. Patient is usually female above 65 years, complaining of pain and inability to bear weight, marked external rotation and shortening because the capsule is attached to the proximal fragment, allowing the distal fragment to rotate freely to the lateral side. No sophisticated examination investigations are needed, just anteroposterior and cross-table lateral view. And in fact, sometimes we are in need to traction internal rotation film to appreciate the posterolateral comminution and better classify the fracture and formulate a plan for management. Do we need CT? In fact, in usual cases, we don't need CT. However, some authors recommending having 3-dimensional CT in complex fracture to break the complex fracture pattern into simple series of reduction steps, and this may affect the outcome successfully. Actually, different classifications are proposed. The AO classification, A1, A2, and A3. And A1 is pertrochanteric simple fracture, multifragmentary fracture of A2, and reversed obliquity in A3. Actually, this is also other classifications. In fact, they are less useful than the classifications of the femoral neck, and it's better to look at as stability of fracture. About 50% of those fractures are unstable. As for the treatment, actually the aim of treatment is to regain mobility and limit the morbidity. And as we said, we have to treat those patients and get them mobile very early to avoid the recumbency problem in pneumonia, urinary tract infection, slow circulation of the skin will lead to ulcers and of course the thromboembolic events. The greatest challenge for the treatment of those fractures are instability and osteoporosis. Sometimes those fractures are actually bad, and the bone quality is bad, and the patient is always sometimes is bad. So it is like a bad fracture in a bad patient. Unstable fractures are actually those fractures that lack the posteromedial support, and those with reversed obliquity, and those with subtrochanteric extensions. The lateral wall, as mentioned by Professor Shafi'i, is very important and a determining factor of the success of the operation. They have some formula to modify. If there is a place for non-operative treatment, actually it is rarely indicated, as Professor Shafi'i said, and should be considered only in non-ambulatory patient with very high risk of mortality intraoperative. Unfortunately, those will lead to more than 80% mortality rate in the first year, in addition to the recumbency problem as shown by Professor Shafi'i. The operative treatment actually of extracapsular or trochanteric fractures, it depends on 5 variables: surgeon dependent and surgeon independent. Surgeon independent, the fracture pattern, the geometry of fracture, the instability or stability of the fracture, and the bone quality of the patient. The surgeon dependent factors actually the quality of reduction, implant choice, and implant position. As my professor Osama Farouk talked about the critical importance of timing in such operations, actually timing is very important in our case, and those fractures should be dealt with as emergent but not urgent fractures. And actually those fractures that is done within the 24 hours have better post-operative outcome, and those delays for 3 or more days are usually associated with increased mortality rate. Time is gold. The second variable is the implants. We have 2 famous implants, DHS and proximal femoral nail. Both of them has its pros and cons. DHS was introduced even in 1970s, even before I was born, and still the gold standard for stable fractures and have something to do with unstable fractures too. And it allows dynamic compression. It is said that the fracture is seeking its own stable position. They have good rate of union and low cost, and this is very important for a country like ours, and of course easy learning. Still they have questionable about the less well unstable fractures, and they have a long lever arm. Proximal femoral nails was introduced in 1996 for unstable fracture by the ISAO. As Professor Muhammad mentioned, the advantage of the closer center of rotation and the shorter lever arm that decrease the bending force in both the bone and implants. Which implant to use? Actually, the short answer is DHS for intertrochanteric stable fractures, proximal femoral nail for relatively unstable fracture. But are short answers enough? Let's explore this. Even though proximal femoral nails have more theoretical advantages, of course, than DHS, there is still ongoing controversy whether proximal femoral nail is a better choice than DHS or not, especially from clinical studies. This is Barton and colleagues published this paper in Journal of Bone and Joint Surgery 2010, and they concluded that DHS should remain the gold standard for treatment of extracapsular fracture, and they found that it have similar outcomes with the gamma nail. Still, it is significantly cheaper. The results of review of literature has no significant advantage of proximal femoral nail over DHS in terms of complications and functional outcome. Another papers reported that DHS was not inferior to intramedullary nailing even for unstable fracture types. And this is a meta-analysis systemic review randomized trials, and it was concluded that proximal femoral nail results in shorter operative time, less blood loss intraoperative compared to DHS. However, there were no difference was seen for the post-operative complications. The important questions actually is when not to use DHS in reversed obliquity fractures, because the failure rate is more than 50%, and in subtrochanteric extension, and if you have lateral the integrity of the lateral femoral wall is questionable, you have to think twice before using DHS. The procedure, it's a simple one: reduction, then guide wire insertion, reaming over the guide wire, screw insertion, and plate fixation. In fact, we consider DHS as an easy operation. I remember it was my first surgery in my orthopedic career, and I was really happy to do that. I think we have to think twice before offering the young resident this operation at the end of the list, because this operation is really critical for the patient. First, we have to start with choosing the right implants. Here is, of course, this is a different choice from one of the orthopedic surgeon, and this is end results. How I do this? I do this operation in supine position under spinal anesthesia, and actually I use flat table. I don't use traction table. Traction table is cumbersome. It needs a lot of time to be reseated, and I'm not really comfortable with. I use a flat table with my assistant doing the holding the traction on the other side of the table, and in the hemolysotomy position to allow the C-arm to get the cross-table lateral view. Actually, you have to ensure that both views are possible by C-arm before scrubbing. You will not do it if you don't see it. Reduction, reduction, reduction. Again, we have, as Professor Osama talked about the predictors of good outcome of surgery as timing and reduction. Here, actually, the reduction is the main determinant of the success or failure of this operation. Reduction is the most important step in this operation and will determine the success or failure of this operation. Why accurate reduction? Because it restores the hip biomechanics, reduce the stress on the implants, and lead to rapid healing. How to reduce? I do flexion, abduction, gradual extension with internal rotation. Sometimes you need to do fine tuning like this. This is one of the last cases. You just need to mildly externally rotate the leg to achieve the good reduction. And you have to be aware of the decustation of those trabeculae, because this is a good site to anchor your implant. You have to use all the possible means, the spike pusher, the pointed clamps, and you may hold this reduction by guide wires. Actually, I usually hold the reduction by guide wires, but you have to put in your mind to avoid the future path of your implant position, to avoid the problem of going with your fixing wire. Remember, 25% of these fractures reduced in slight external rotation, and also 1/4 of those fractures doesn't need abduction. How you assess the reduction? The neck shaft angle should be normal or slight valgus. Sag of the femoral shaft should be avoided. Displacement should be less than 5 millimeters of any of the bone fragment. Rotation can be judged clinically. And on the lateral view, you have to find the anteversion, which is around 15 degrees, and you have to ensure continuity of the anterior cortical line. You have to avoid heavy traction, because it will lead to valgus. More valgus is not appreciated. And too much internal rotation that will open the posterior cortex. Actually, this is the tip apex distance, which is a summation of the distance from the tip of the screw to the apex of the femoral head in the AB and lateral view. And this is a very important determining of the success of this operation. It is a strong predictor of the cutout, and it should be always kept under 25 millimeters number. This is also lesser trochanter is intact. The proximal fragment will be flexed, abducted, and externally rotated. Reduction will be difficult. If all possible, you have to put that in your mind if you inspect the X-ray and find the lesser trochanter is intact. The approach is slightly posterior to the mid-axial line. The guide wire should be using the guide angle, and this angle should be flushed with the shaft of the femur. The guide should be central in anteroposterior and lateral view, and ideally it should be at the level of the lesser trochanter. All the time check with C-arm, and this is the fixing wire and the guide wire that we will use to fix our implant. Reaming should be done over guide. Please avoid bending of the guide. It may be broken, and be careful about shouldering. because sometimes you broke the lateral wall intraoperatively, and this occurs in a very good deal of numbers in those cases. And here you are transferring this case from stable to unstable, and you will need another implant to support your fracture. The screw position should be ideally central in the AP and central in the lateral. More important is the tape apex distance. And if difficulty encountered, slightly posterior and inferior positions are accepted. Tab or not, we tab actually in young patients, and we have to consider always the stabilization of the proximal fragment by guide wire while we are tabbing. And if we are going to tab, we have to tab 5 millimeters length than the reamed area. Of course, you have never to force the plate on the screw. And another very good option or aid, which is the TSP or trochanteric stabilizing plate. We have to use this plate in case of lateral wall comminution. And actually, I sometimes used T plate if this plate is unavailable. One of them is named after our great Professor Muhammad Shafi, the preceding speakers. We always consider a Shafi plate in your instrument, on your plates. And actually, if not available, you have to keep one T plate. The disadvantage of T plate, of course, is it will change the dynamicity of the implant into a fixed angle plate, because it doesn't have this hole corresponding to the lag screw. However, if you can't find the TS plate, you can use this T plate. In fact, trochanteric stabilizing plate in the treatment of trochanteric fractures, this was published in Acta Orthopedica in 2021. It provides a more stable construct, reduce the lag screw sliding and medialization. However, this is translate into improved clinical outcomes or not, it is unclear. This is another paper comparing BFN against DHS with TSP for unstable fractures, and the conclusion is they have both comparable outcome and good results. This is a very nice implant I came across in the last CCOT was held in Egypt. One of the booths of one of the companies, I don't remember from which country, but they do this plate, and it have an posterior extension. I think it will work well for the supporting fracture. These are my photos. Right or left side, does it matter? Actually, it doesn't, but you have to be careful, because in the right hip, you tighten the screw in clockwise manner, which will be stabilizing the fragment towards the shaft. In the left, you may elevate the proximal fragment, and you have to put that in your mind and to fix a guide wire or something to avoid this position. Cement augmentation in severe osteopenic pain improves the screw purchase and prevent screw cut out. We have did a paper published on this issue. For the sake of time, arthroplasty was talked well about Professor Muhammad Shafi, and he is introduced very amazing cases. He said, as he mentioned, there is a high rate of complications, maybe 5 times mortality rate, and of course it should be preserved for those old patients with severely unstable and bad quality bone. And thank you very much.
Thank you so much, Professor Said, for this very interesting talk. We have some questions to you before moving to the next speaker, please, sir. First question from Dr. Gamal Qasim is rule for non-operative measures if the fracture is stable, especially if comorbid patients?
I think you have to live or not to live. This is a bad judgment of mine, but I think it's better to put the DHS for this patient, which is really simple in those patients, and get this patient ambulatory, turning on bed, avoid bed sores, avoid the recumbency position. I am not with non-operative approach, absolutely.
Yes, sir. Another question, sir, for Dr. Said. How do you set up the patient in flat table? What about the lateral views, and can you do it for PFN as well, sir?
Yes, I use it also for BFN. As I said, and I put a picture from my theater, I put the patient in the hemilysotomy position. This will open the way to have your lateral X-ray cross table without need to move the leg. And also I use the same approach for BFN too.
Yes, sir. Another question from Dr. Khalid Muhammad. How you maintain the traction throughout the surgery without traction table? How support the patient against traction without the traction table, sir?
As I said, I do the reduction. Fortunately, most patient doesn't need a lot of traction. Actually, sometimes if you do overdue traction, you will lead to a valgoid situation. In fact, I used one of my assistant to hold the leg throughout the procedure. And as I said first, once I reduced the fracture, I try to put a guide wire to support the reduction, and you have to put on your mind to have another path away from the expected path of the next screw position.
Yes, sir. Another question from Dr. Ahmed Hamdi. When we use a T-plate with DHS plate, Dr. Saidi?
Actually, the indication of use the TS plate first if there is a questionable integrity of the lateral wall. Actually, if the lateral wall is fractured or thinned up to 2.4 centimeters, it is expected to be fractured. So we use it in if there is questionable integrity of the lateral wall first, and we use it in unstable type of fractures. Of trochanteric fracture, unstable types and lateral wall integrity questionable.
Yes, sir. One of our attendees, our dear colleagues, is asking about can we have the material? Of course, all the material, sir, if you excuse me, will be available on the YouTube channel of the Egyptian Orthopedic Association within 2 weeks from now.
Inshallah.
We have another question from Dr. Sadiq. What about using DCS plate in unstable fractures and the scale of the patient?
Actually, there is a definite indications of DCS. I exposed one of the implant choice, one of the surgeons that used DCS for trochanteric fractures. Actually, this is not the indication at all. The indication of DCS is the subtrochanteric fractures and not the trochanteric fractures. There is no rule of DCS in trochanteric fractures.
Yes, sir. One is asking about, one of our colleagues is asking about what about the lateral position in PFM?
Actually, it should be theoretically easier to have the lateral position. I usually to make it simple. Simple is simple. It works for me to have the flat table, and so far I can run my C-arm and get the lateral view and the intraposterior view easily. I don't need to. Actually, the traction table is cumbersome. It has a lot of parts, at least in my hospital, and to set this traction table, I need a lot of time, more than 30 or 40 minutes to set it the right way.
Yes, sir. The last question, sir, from Dr. Akila. What about version correction when supplying side plate, retro or anti or non-traction table?
Sorry, I didn't get you.
What about version correction when applying side plate, retro or anti or non-traction table?
If I understand the question well, I usually insert the DHS under C-arm image, and I usually keep the neck version within the 15 degrees of normal anti-version of the hip.
Yes, sir. The last question, sir, because we have to stick to time, from Dr. Kamal.
Of course.
If the reamer went more into the acetabulum, what should I do?
The reamer, it shouldn't. It shouldn't. But anyway, what happened is happened already. But you have to be shortened your lag screw to avoid migration of the screw within the acetabulum.
Yes, sir. Thank you so much, Professor Said, for this very interesting presentation.
Thank you.
We will have to move to the next speaker. Our next speaker will be Professor Amr Azam, Professor of Orthopedic Surgery, the National Institute of Locomotor System. Professor Amr will speak about the updated surgical technique of safe surgical dislocation. Thank you so much for joining us, sir.
Thank you, Professor Muhammad. It's a pleasure for me to share in such an international